Happy evening, everyone. Welcome to this new episode of GarbhaSandesha. My name is Hari Srinivasan. I'm going to be your host today. Welcome to the show, Dr. Priyanka and Dr. Anitha.
Happy evening.
So today's topic is know everything about ovulation induction with timed intercourse. It's a very interesting topic. Very rarely do we see this topic being addressed in either talks or seminars. This is like a stepchild, right? People talk about IUI, people talk about IVF, PGT, all of the complicated things. But OATI is probably one of the easiest, most effective things. So let's talk about that today. To discuss this topic, we have two stalwarts with us. Dr. Priyanka. Dr. Priyanka Rani is a senior fertility specialist. She used to be a gynecologist, then did a super specialization in infertility. She consults at our Electronic City Center. She's the lead consultant there. Welcome to the show, Dr. Priyanka.
Thank you, sir. Pleasure to be here.
We also have Dr. Anitha Manoj with us. She is a fertility specialist with good experience and she consults at our Hanuman Nagar Center. Welcome to the show, Dr. Anitha.
Thank you, sir.
Looking forward to a very engaging conversation today with both of you and our audience. Okay. So let's start with some opening statements from Dr. Priyanka. Dr. Priyanka, over to you.
Yes. As very nicely you have introduced, sir, and ovulation induction is a very simple method of inducing ovulation. So basically there what we are doing is a lady who is not able to ovulate by herself, we are trying to help her with the ovulation. And it's a very simple method, very safe method if it is done in the correct way. And it is quite effective also if the right choice has been made. I mean, the patient selection, if it is proper, we get good results and it is very cost effective also. And we have seen good results with our patients. So a good topic to discuss, sir, and good things.
Okay.
And I'm sure patients will benefit a lot from this discussion.
Super. Thank you, Dr. Priyanka. Dr. Anitha, over to you. Anything you want to start before we start taking questions from our audience?
Yes, sir. See, normally in a normally menstruating women, like 28 days or 30 days cycle, a woman always, she starts ovulating by 14th to 20th day. One egg will be developing and one egg will be releasing in a natural scenario. And during that time, intercourse during that time will help her to conceive. But in many people, like around 25 to 30% of the infertile couples who walk into our OPDs, the basic problem will be anovulation. That means they are not able to ovulate. Either they will have irregular cycles or the cycles might be regular, but the ovulation won't be happening. It can be because of the PCOD or it can be because of the weight gain or multiple factors. In such females, treating with the basic treatment modalities like ovulation induction, either directly or indirectly. There are different methods which we will be discussing later or ahead. So this will help with the simple treatment method. Most of the people, around 50 to 60% of the people with other normal parameters, they will conceive. So that is why we give so much of importance for this method, that is ovulation induction and time intercourse. So one is with the basic treatment method, and that expenses also will be very less, and they'll conceive also quickly with minimal interference.
Okay. Yeah, that's the important part, the minimal interference. So good introduction, Dr. Anitha. Okay, so Dr. Priyanka, over to you. So can you please start with the overview of what we mean by ovulation induction and timed intercourse? I know both of you already answered this question, but I just wanted to make sure that we give this overview to our audience and then start taking questions on that.
So when we talk of ovulation induction, one very important fact is the initial analysis of the lady and assessing whether such treatment is appropriate to her or not. So to understand that, as Dr. Anitha was also mentioning, so a lady would ovulate somewhere between day 10 to day 15 of her cycle if the cycles are regular. Some women do not ovulate or they ovulate very erratically. It may be earlier or it may be happening later, or they may not be ovulating at all. So these are the women who would benefit. The other thing is where there are no other obvious or very other severe diseases which are there, like the sperm parameter should have been normal, more or less, with minor variations are acceptable. But if there are major changes, if the lady is having severe endometriosis, then ovulation induction will not work out in them. So we need to properly analyze and assess how useful it will be. So how we do that is when lady walks in the initial visit, especially on the second or the third day, we do a scan and see whether there are any cysts or not. We assess everything is normal, the ovary, the egg count should be normal, her age should be appropriate. So ovulation induction would work out in a women, or we would get good success results for a woman who is less than 30 years. As the age advances, the chances of success with simpler treatments like ovulation induction would be lesser. So the couple need to understand that. Sometimes we've come across couples who insist after like trying 8 to 10 cycles of ovulation induction, they are still not ready to accept further treatments. So this is something which they have to understand. There are many factors which have to be analyzed, and the same treatment will work for some, it may not work for some other group of patients. So that is one thing which we need to keep in mind. Then how we go about it is, as the term says itself, ovulation induction. So we are going to induce ovulation by giving certain medications, which would either be tablets or it may be injections, based on what the clinical profile of the lady is and how her previous response has been with similar kind of treatment. So it is usually given for a duration of about 8 to 10 days, wherein we do serial scans. And this I want to emphasize more because I've come across women who have been given treatments for 8 to 10 days, not monitored completely, and they land up with hyperstimulation. That is, many follicles are growing at the same time, which is again a not good thing to come across. So very important to be done in safe hands, and it has to be carefully monitored. A day 2, day 3 scan is a must. And then we keep doing follow-up scans to make sure at least 1 or 2 follicles should be growing. It should not be too many follicles which are growing, in which case we usually cancel the cycle. And once the follicle is ready, that is, we measure the size of the follicle, it would look like a water bubble in the scan, inside which the egg will be there. The egg cannot be seen on the scan. So we usually say the egg is growing, but actually it's the water bubble inside which the egg is growing. We measure that, and then once it has crossed 18 to 20 millimeter size, then we give them injection for the egg release, wherein the water bubble bursts open or the ovulation happens, and we expect the egg to be released around that time. And we usually tell them to have intercourse during that particular period, after which certain tablets are given to support the pregnancy further. So this is how we usually go about ovulation induction.
Okay, that's a very comprehensive explanation, doctor. Thank you. Dr. Anitha, the question is to you. See, we've been, all three of us have been talking about ovulation induction. So for a layman, can you in simple words tell what ovulation induction is? Why is it needed?
Yes, sir. So that's what when I gave the introduction also, I told there are so many factors. So mainly 4 factors are important for the pregnancy to happen naturally. One is egg release for the women. And another, second is the tubal patency. The tubes has to be patent. They should not be like blocked. Not only blockage, they should be healthy also. Third factor is, which we all know, uterus should be normal. That means uterus should be neither big or small, no infections, no masses like fibroids or polyps. And the fourth factor is male factor, that is semen analysis should be normal. These 4 factors are important for any couple to achieve pregnancy naturally. So here today we are concentrating on this ovulation, assuming the other 3 factors are normal. That is, the tubes are patent, the uterus is normal, and the uterus lining is normal, and the male factor, that is semen analysis, is normal. So in this, that means the ovulation is not happening. So naturally it has to, every month, one, like around 8 to 10 follicles will be there in a normal female. So in that one follicle which has an egg, which will be selected naturally by the body, and that follicle will grow and it will get released. That is, egg gets released around 14th day in a 28-day cycle, plus or minus 2 days. So if this is happening, then the rest of the things will happen. That is contact during that time, fertilization, and then pregnancy, all those things. If this is not happening naturally, that is ovulation, that egg release is not happening, then the pathology is where the problem female is having is like not able to release the egg, that is anovulation. So in such patients, when the other 3 parameters are normal, we do help them medically by giving medicines directly or by doing certain procedures or by giving some advice which indirectly helps them to ovulate. That is called ovulation induction. That is, we are inducing the patient to help to ovulate, to release the egg. That is ovulation induction. There are different methods which we will deal.
Okay. Very clearly explained, Dr. Anitha. Thank you. So, Dr. Priyanka, we have a question from Shashi on YouTube. The question is, I am having 30 to 33 days monthly cycle. How will I know when I am ovulating? Can you please explain? Are there ways to identify when I am ovulating? Are there clinical ways and other calculators which I can use for identifying when I am ovulating?
So it is very commonly asked question which we've come across many times, and normally a lady who is having a 33 day cycle up to 35 days is considered as normal, and it is important to have a similar duration of cycle in the in the preceding 6 months. So over 6 months, if the lady's cycle duration is around 35 days, then we can approximately say that we can do half of it. So around probably day 17 she would be ovulating, so plus minus 5 days. So from day 12 to day 20 or 21 would be her expected duration of ovulation. So for her it will be around day 15 to day 21 when she can expect the ovulation to be happening. And how she can assess at home is, there are certain LH kits which are available, or ovulation kits. They are available over the counter and they can be tested from the estimated duration of ovulation on alternate days, and whenever it is positive, they can have intercourse. So that is one method of doing it. There are other methods like checking the basal body temperature and checking the change in the cervical mucus. The mucus which is secreted becomes longer around the ovulation time. So these are other methods, but they are not very specific. So the best thing which we usually advise to our couples is by doing a urinary LH kit, or if they can come or visit their gynecologist, they can get a scan done, which again will help in identifying when the ovulation is happening, and they can try around that time.
Okay. We that was hope Mr. Shashi understands the answer there. There are also ovulation calculators available on our website and also other websites, which gives a fair idea of the ovulation duration. But again, as doctor explained, it is always better to get a scan done or use a LH kit. Okay. Dr. Anitha, the next question is for you. It's a follow-up question on the same topic. Suppose a couple have been advised OI, ovulation induction with timed intercourse. When is it that they need to plan their intercourse? See, as Dr. Priyanka explained, the duration is rather wide, right? About 7 days to 10 days. So is there any specific day or days when they need to plan to be in contact?
Yes, sir. See, this question we have answered in our prior sessions also, like we told about that fertile window and all those things. Here, that fertile window comes in the natural cycle, the way they're following, that calculators they are using. So around the ovulation time, they have to be together, couple have to be together. A minimum frequency should be at least alternate days. Why this minimum frequency is because the sperms, they have a viability of around 48 to 72 hours. So that is why the minimum frequency should be at least alternate days. It doesn't mean that they should not be together daily or more than once daily. It is only minimum frequency. And if we are going for ovulation induction and we are monitoring, like if you are doing that, as Dr. Priyanka said, urinary LH kits you are using to monitor the ovulation. Once the LH kit shows positive, the next 3 to 4 days, they have to be in contact. That is like in next 3 to 4 days, ovulation is expected, and next 3 to 4 days, they have to be continuously, they have to be together based on the kids. And another way is like if you are monitoring by the ultrasound, so once we do the follicular growth reaches optimum size reaches, the doctor will give an injection for the follicle to release the egg. So once we give the injection, we'll ask them to be together continuously for 3 days. See, if I'm giving an injection today for the egg to release, so what we expect is around 36 hours later, we expect for the egg to release. So we ask them to be together for the next 3 days, like tomorrow, day after, and the next day. So this is how the timed intercourse is planned in ovulation induction cycles.
Okay, thank you. Dr. Priyanka, see, we spoke about both natural ovulation induction, natural cycle of OITI, and also something that is monitored and managed by a fertility specialist or a gynecologist. How are they different, Dr. Priyanka?
So when we are talking in terms of natural cycle with timed intercourse, most often it is the patient who will be monitoring the cycles themselves, and they will be assessing. And sometimes these LH kits, as I was telling, they may not be very specific. You may get false positive results also. So they may be assuming that they are ovulating, but they might not actually be ovulating around that time. And though natural cycles are considered to be very good cycles because everything is happening naturally, the egg has grown naturally, and the endometrium or the inner lining of the womb will be very favorable in such cycles. And but in some women, especially who have a condition called luteal phase defect, though they might be ovulating on time, but the hormone levels may not be appropriate to support the pregnancy. So when we do ovulation induction, it takes care of that aspect as well. So we've come across women who have ovulatory cycles. They do ovulate naturally, but they fail to conceive. And we find that there are no other specific factors. Tubes are normal, semen analysis is normal, but why they're not able to conceive? So they need that little extra support, which is provided by ovulation induction. So these drugs which are given, they change the hormone levels in such a way and make it so favorable that the egg release is of good quality, and plus the endometrium also is favorable. It is monitored, and sometimes when it doesn't look favorable or it is not corresponding to the size of the egg, so when the egg is growing, simultaneously the endometrium or the inner lining of the womb should also grow accordingly. If the egg has grown fast, the lining is still thin, despite having ovulation, pregnancy may not happen. So when we monitor these cycles, we are able to give hormone tablets, and we are able to make the endometrium also grow along with the egg. And then once the ovulation has happened and they've had intercourse correctly, we do support the pregnancy. The initial phases of pregnancy is very important. Some women need that little extra support during that time, even in a natural cycle. So when we adequately supplement with hormones like progesterone during that phase, the outcomes are always better. So natural will be more physiological. It may work for some women, but when we monitor, we are taking care of all the factors which can go wrong and making giving it the best for the natural method itself.
Okay. So what are these tablets or injections? What are these ovulation inducing medicines, Dr. Priyanka?
So as I told earlier, there are two categories. Normally we give tablets. We start with tablets. There are 2-3 different groups of tablets which we commonly give them. And based on how they have responded in the first cycle, we would increase the dose of the tablet or change the protocol, or we can only consider giving injections, or sometimes we give a combination of tablet with injection to induce the ovulation. All would depend upon how they have been responding, how the hormone profile is. So all this is important before we start the ovulation induction. Carefully assessing what our hormone levels are. So normally we do a day 2, day 3 FSH, LH level. We check for the egg reserve, and just giving drugs will not help. We also have to ensure that the thyroid levels, the sugars, everything is under control. Another very important hormone is prolactin. Even that should be under control. If these are not controlled simultaneously, then even if we are giving ovulation induction, it will not help. Like recently, one of my patients, she had come with a history of having a very high TSH, and the general gynecologist whom she was consulting had overlooked that fact, and she had a huge cyst, and she was advised surgery for that cyst. She was very apprehensive. She came to me for a second opinion. I examined and I realized that that was a very simple cyst which can just be controlled with tablets. But what I felt was a major problem was her thyroid levels. And she had been trying for pregnancy for 1 year. Once I just gave her one cycle of contraceptive pills, gave her tablets, consulted an endocrinologist, gave her appropriate dose of thyroid hormone. The next cycle itself, she conceived, and she was herself surprised that why it was not happening in the past 1 year and what happened in 1 month. So it can be so critical. I mean, little variations here and there, if they are overlooked, no matter what treatment you try, doesn't work out. So all has to be a holistic approach.
Oh, super. Okay. Dr. Anitha, actually 2 questions. What are the situations in which ovulation induction with timed intercourse is not appropriate? And generally, what are the success rates that people can expect with the OITI cycle?
So in generally, that's what around 25 to 30% of the couples, as I already quoted, they'll have only the ovulation problem. So only the ovulation pathology in such, and other 3 factors, as I already mentioned, they are normal. In such patients, we can go ahead with the ovulation induction and they might help them. And the success rate with this might be around 30 to 40% only. We cannot say that all the couple with only this pathology, ovulation pathology and other factors normal, they'll conceive 100%, they'll conceive with the ovulation induction. It's not, it may not be true. It's not true actually. So only 30 to 40% will conceive with this method. And in what conditions it won't suit means, see, for example, like as Dr. Priyanka said, we have to, it has to be holistic approach. There should be other parameters also, like other endocrine pathologies like thyroid, prolactin levels, all these things we have to consider. And other thing is like dense PCO, like not just the PCO, the too much of PCOD patients. There also such things may not be possible. And in like where the egg count is less for them, that like what do you say, poor responders, where the egg count is less, and age also, like advanced age. So in such patients also, and just doing ovulation induction, and married life is long, like more than 5 or 6 years of marital life, and now they are coming, and the age factor is also there for both the couple, and wasting their time in trying for ovulation induction in for that 30% of chances will be little be very costly method, costly approach. So we want to go a little faster to treat them. So in such patients also, and people who are obese and overweight, for them also, like how much ever you give, they may not respond. Even if they respond, the quality of the oocyte might be like compromised. So such patients also we do, like you keep doing multiple cycles, like 6 to 8 cycles, still ovulation, we are documenting ovulation in the scan, still it is not happening. So these things also we have to look into and consider which patient we have to take in, which patient we should suggest some other method of conception.
Okay. Dr. Priyanka, both Dr. Anitha and you are mentioning about age as a crucial factor for OITI selection, right? Why is age such a crucial factor?
So age is one of the most important factors which determines the success or with IVF or IUI. So any woman who has crossed that age of 30 years, can you hear me, sir? Sorry.
Yes, we can.
So any woman who has crossed the age of 30 years, the egg reserve comes down. So the number of eggs are lesser, and it goes on reducing with each year which is passing by. And the overall biological aging is happening. with the reduction in number, the quality also reduces. That is, the chances of baby having abnormalities become higher with the advancing age. So a woman who is above 40 will have almost like 35 to 40% of chances of having a baby with abnormalities. So though they might be ovulating, but the appropriate treatment for women who are in advanced age, especially beyond 35 years. We have to be very careful in our choice of treatment for such women.
Okay, okay. Dr. Anitha, there's one question. If the periods of a lady are not normal, we said that anything between 26 to 35 is normal period cycle. But if it is more than that or much lesser than that, can those patients also be advised OATI?
Yes, it's like, see, the first thing is anovulatory cycles might be regular or irregular. If the patient is having irregular cycles, first we can if there is prolonged infertility, like married life is longer, prolonged infertility is there, and they are having either frequent cycles or delayed cycles like oligomenorrhea. In such cases, definitely ovulation induction will help them, because such patients, like almost 80 to 90% of the couples or patients with irregular cycles, they will have ovulation dysfunction actually. So ovulation will be difficult. So such patients, treating with the ovulation, keeping in mind the other factors, then it will definitely help them.
Okay, okay. Doctor, we have a question. My OATI cycle resulted in a pregnancy and then miscarriage, and this has happened twice. What is it that I have to do now? This is for Dr. Priyanka.
So we very often come across this scenario, and as I was telling, luteal phase defect is a very important factor to be considered. Most often it goes undiagnosed, and there are no real methods or like proven methods to actually diagnose this. But what happens in some cycles is there is not enough of hormonal support for the initial pregnancy. So such women would need early support with progesterone in the beginning. And we also, and it's very difficult to actually pinpoint and say.
Dr. Anitha, I think Dr. Priyanka has a network issue. You can continue with the answer.
Yes, sir. So that is what Dr. Priyanka was telling about the luteal phase support. So when the pregnancy happens, either naturally or by ovulation induction or by IUI, so any pregnancies, we have to go with the luteal phase support. That might be one of the reasons for these abortions. And other reasons can be microthromboembolisms in the uterine vasculature, which is supplying the blood supply to the baby. So we'll give
that was too much for us to understand, Dr. Anitha. Very difficult words for us to understand.
So we'll give certain medicines to prevent abortion, that is called luteal phase support. And other than that, we'll give certain medicines to prevent the clotting of the blood, so that the baby will receive a proper blood supply from the mother. So we'll give certain medications for that also. And if majority of the cases, like if the abortions are happening in the first, like less than 8 weeks, so mainly it depends upon the quality of the oocyte, that is the egg, quality of the sperm, and quality of the embryo also. That means and on top of that, there are some genetic factors which we may not be visible to us, so which we have to evaluate. So there are clinical factors, genetic factors, like anti-phospholipid antibody syndrome, anti-nuclear antibodies, or torch profile, like torch infections also, infection pathology also. All these things, if we have to rule out first, because if it is only one pregnancy loss, it might happen in 60 to 70% of the cases. We might take it as normal, and it may not repeat in the second pregnancy. If 2 consecutive pregnancy losses are there, then definitely the couple has to go for evaluation. Like as I said, evaluation, find out where the pathology is, and treat accordingly before the 3rd pregnancy.
Okay. Dr. Priyanka has not joined yet, so my question again will be to you, Dr. Anitha.
Yes.
There's a question saying, my doctor told that my OATI cycle has failed as follicles have not developed even with medicines. What is the next step that we have to follow?
Yes, sir. See, for the anovulation, as I already mentioned, there are many causes. One, it can be like weight of the patient, obesity or weight overweight, and then like PCOD, which is the commonest cause in present day scenario, or it can be age factor also, like elderly patient, or it can be early premature, like ovarian failure. That means early depletion of the follicles, though she is only young, around 30 plus, still the follicular pool, that egg pool is less for her. So in such patients, the response might be different, and we will be doing the ovulation induction different ways, like either direct or indirect.
Okay.
Indirect means advising. The first thing what we do is advising lifestyle modifications. If she is overweight or obese, we'll ask her to go for weight reduction. Once there is 5 to 10% of weight reduction in her, like of her original weight, that weight losing tendency starts, her ovulatory function resumes naturally. And they will, even if we treat them also, they'll respond beautifully with our medicines. Along with that, we'll be giving other if they are not going for like dense PCOD, as I said, more than 20 follicles on either side, then we will be going for the surgical approach, like ovarian drilling, where there is ovarian drilling, where the androgens, that is male hormones in the body, will get reduced. This will induce ovulation, and this will help the patient to respond to the treatment. If she is not responding to, say, first cycle, for example, one patient is walking to my clinic, everything is normal, I'm planning to start ovulation induction. I have given oral medications to start the egg development. So I am finding like day 10, day 12, she's not responding. I can add on with the gonadotropins. These are the hormonal injections. I can add on them and see whether she is, but we should add only the low dose. If we give a higher dose, she might respond all of a sudden with multiple follicles, and we can go for complications also. So we can add on this. So, or the next cycle, we can start with a higher dose of the oral medicines, and then add additionally a smaller dose of gonadotropins also. And the other way is directly start with the gonadotropins, low dose gonadotropins, and slowly increase. That is the step-up method. Slowly increase till she responds with the lifestyle modifications.
Yeah, sorry, a lot of network issues today.
Yes, sir.
Okay. I missed the last part of the answer, so I'm assuming you completed it. I'll just go to the next question. So what happens in cases where the husband has erectile issues or erectile dysfunction, those sort of issues? Is OITI a possibility, Dr. Anitha?
Sir, see, if the husband is having erectile dysfunction, for them intercourse will be it's a challenging thing for the couple. So in such cases, what we do is, yes, we can go with the next level of treatment. That is, we do ovulation induction, we monitor the egg development, and we go for the intrauterine insemination, where though husband has erectile dysfunction, he'll be able to collect the sample and give. So in such cases, husband's sample will be collected, washed and purified. The motile good quality sperms will be directly placed in the uterus close to the tube, so that the egg and the sperms will meet. This is one method where we can help them. Doctors will do the intrauterine insemination, or as the patients also under like sterile methods, even at home, they can use the sterile methods and inseminate themselves, self-insemination into the vagina. Instead of uterus, into the vagina itself, they can collect the sample outside under sterile conditions. Keep in mind, if they just do haphazardly anyhow like that and all, then they will land up in infection, which can damage the future fertility also. So sterile conditions, self-insemination also can be done. Other than in vitro fertilization, these two methods, self-insemination and intrauterine insemination with ovulation induction, will definitely help the couple with the erectile dysfunctions.
Okay. I think we are getting Dr. Priyanka back. Okay. Yeah, well, she gets everything. Okay, Dr. Priyanka is back. Welcome back, Dr. Priyanka.
I'm sorry, there's some network issue.
Okay. Yeah. So this question is to you, Dr. Priyanka. So if the lady has complaints of endometriosis, is OITI a possibility?
In endometriosis, usually they'll have lesser chances of pregnancy with OITI methods. Usually in them, if it is mild disease, we recommend 1 or 2 cycles if they have not tried for pregnancy earlier. If the tube is normal, overall egg reserve is good, then OITI can be tried, but not for more than 2 to 3 cycles. But women who have severe disease like stage 3 and 4 endometriosis, for them, OITI is not going to work out. For them, we have to plan advanced treatments. So based on their stage of disease and how severe the disease is, how good the tubes are and the ovarian reserve, we need to take a call whether they are suitable for ovulation induction or not.
Okay, okay. Dr. Priyanka, you can take the next question also, because Dr. Anitha answered 3-4 of them continuously. So the next question is, are there any special dietary changes or lifestyle modifications that the couple have to implement in their life, I mean in their day-to-day life, to help increase the success rate of ovulation induction and timed intercourse?
As I have already been, I usually emphasize this to all my couples who come. It is having a pregnancy has to be a very holistic method of whatever treatment, or we have to have a very holistic approach towards it. Just giving drugs and inducing artificially ovulation is not going to work out unless there is some effort from the patient side, especially if she's overweight. If they put in some effort, do regular exercises, taking a good nutritious diet which is rich in vitamins and antioxidants, that all will help in improving the egg quality. Taking their medicines on time, taking their thyroid medications if they are taking, controlling the sugars and avoiding sugars, high sugars in diet, taking more of high protein diet. These all are also very important aspects. Likewise for the male partner as well. So if the husband has been smoking or taking too much of alcohol, those factors again will be working against what treatment we are giving. So these things are modifiable factors which can easily be taken care of by some motivation from their side. So it's not only the doctor's job, they have to help us by doing things from their side as well. So when both efforts are there in the right direction, only then pregnancy can happen, is what I strongly feel. So I always emphasize this to my patients, that I'm going to do my part, but are you going to do your part? And how committed or how dedicated you are to doing that, that will also determine your success rate.
True, true. Very valid point, Doctor. Dr. Anitha, we have a question from Sridevi Pramod on YouTube. Ma'am, I have very small uterus, periods are not normal, no periods and normal ovaries. Can I get pregnant? And please answer in Kannada if possible. Dr. Anitha, this is for you.
Okay, sir. See, I'll speak in Kannada, sir.
Yes, ma'am. Please.
So, she's Sridevi, no, sir?
Sridevi Pramod. Yes, ma'am. Houdu.
Mrs. Sridevi ಅವರೇ, ನಿಮ್ ಹೇಳಿದ್ದು ನಮ್ಗೆ ಅರ್ಥ ಆಯ್ತು. ಗರ್ಭಕೋಶ ಚಿಕ್ಕದಾಗಿದೆ, ಬಟ್ ಅಂಡಾಶಯಗಳು ನಾರ್ಮಲ್ ಆಗಿದೆ, ಬಟ್ ಪೀರಿಯಡ್ಸೇ ಬರ್ತಾ ಇಲ್ಲ ಅಂತ ಹೇಳ್ತಿದ್ದೀರಾ. ಸೊ ಫಸ್ಟ್ ಎವ್ಯಾಲ್ಯೂಯೇಟ್ ಮಾಡ್ಬೇಕು. ಅಂದ್ರೆ ಲ್ಯಾಪ್ರೋಸ್ಕೋಪಿ ಅಂತ ಒಂದು ಇದಿದೆ, ಸಣ್ಣದಾಗಿ ಒಂದು ಪೆನ್ ಸೈಜ್ ಕ್ಯಾಮರಾ ಹೊಟ್ಟೆ ಒಳಗಡೆ ಹಾಕ್ಬಿಟ್ಟು ವಿಲ್ ಬಿ ಸೀಯಿಂಗ್ ಗರ್ಭಕೋಶ ಎಷ್ಟಿದೆ ಅಂತ. ಒಂದೊಂದು ಪೇಷಂಟ್ ಅಲ್ಲಿ ಅದು ಚಿಕ್ಕದಾಗಿರುತ್ತೆ, ಇಲ್ಲ ಒಂದು ಬ್ಯಾಂಡ್ ತರ ಫಾರ್ಮ್ ಆಗಿರುತ್ತೆ, ಇಲ್ಲ ಆಬ್ಸೆಂಟ್ ಆಗಿರುತ್ತೆ. ಹಾಗೆ ಮಿಕ್ಕಿದ ಆರ್ಗನ್ಸ್ ಲೈಕ್ ವೆಜೈನಲ್ ಡೆವಲಪ್ಮೆಂಟ್ ಅದೆಲ್ಲಾನು ನೋಡ್ಕೋಬೇಕು. ಜಸ್ಟ್ ಚಿಕ್ಕದಾಗಿತ್ತು ಬಟ್ ಗರ್ಭಕೋಶ ಫಾರ್ಮ್ ಆಗಿದೆ, ಚಿಕ್ಕದಾಗಿತ್ತು ಅಂದ್ರೆ ಮಾತ್ರೆಗಳು ಕೊಟ್ಟು ಅದನ್ನ ಸ್ವಲ್ಪ ಬೆಳೆಸಿ, ಒಂದು 6 ತಿಂಗಳು 7 ತಿಂಗಳು ಬೆಳೆಸಿ ಆಮೇಲೆ ಕೂಡ ಟ್ರೈ ಮಾಡಿ ನೋಡ್ಬೋದು. ಹಂಗಿಲ್ಲ ಅಂದ್ರೆ ಇದು ಮುಂಚೆ ನಿಮಗೆ ಲೈಕ್ IVF ವಿಲ್ ಬಿ ದ ಮೋಡ್. ನಾರ್ಮಲ್ ಮೆಥಡ್ಸ್ ಅಲ್ಲಿ ಕನ್ಸೀವ್ ಆಗೋ ಚಾನ್ಸಸ್ ಕಷ್ಟ ಆಗುತ್ತೆ ನಿಮಗೆ. ಯು ಹ್ಯಾವ್ ಟು ಗೋ ಫಾರ್ ಅಡ್ವಾನ್ಸ್ಡ್ ಟ್ರೀಟ್ಮೆಂಟ್. ಅಂದ್ರೆ IVF ಮೂಲಕನೇ ಆಗ್ಬೇಕು. ಫಸ್ಟ್ ಅಂಡಾಶಯಗಳನ್ನ ಸ್ಟಿಮ್ಯುಲೇಟ್ ಮಾಡಿ ಎಗ್ಸ್ ನ ಬೆಳೆಸಿ, ಎಗ್ಸ್ ನ ರಿಟ್ರೀವ್ ಮಾಡ್ಕೊಂಡು ಭ್ರೂಣಗಳು ಮಾಡಿ ಇಟ್ಕೊಂಡು, ಆಮೇಲೆ ಗರ್ಭಕೋಶ ಚಿಕ್ಕದಾಗಿತ್ತು ಅಂದ್ರೆ ಮಾತ್ರೆಗಳು ಕೊಟ್ಟು ಗರ್ಭಕೋಶನ ಬೆಳೆಯುತ್ತಾ ಇಲ್ವಾ ಅಂತ ಚೆಕ್ ಮಾಡಿ ನೋಡ್ಕೊಂಡು ಇದ್ ಮಾಡ್ಕೋಬಹುದು. ಹಾಗಿಲ್ಲ ಬ್ಯಾಂಡ್ ತರ ಇತ್ತು ಅಂದ್ರೆ ಮಿಕ್ಕಿದ್ದನ್ನು ನೋಡ್ಕೋಬೇಕು. ಅಂದ್ರೆ ಕ್ಯಾರಿಯೋಟೈಪಿಕ್, ನಮ್ಮ ವಂಶವಾಹಿನಿ ಟೆಸ್ಟ್ ಅಂತ ಹೇಳ್ತೀವಿ, ಜೆನೆಟಿಕ್ ಅಬ್ನಾರ್ಮ್ಯಾಲಿಟೀಸ್. ಸೊ ನಿಮ್ಮಲ್ಲಿ ಆ ತರ ಪೆಥಾಲಜಿ ಏನಾದ್ರೂ ಇದೆಯಾ ಅಂತ ಕ್ಯಾರಿಯೋಟೈಪಿಂಗ್ ಒಂದು ಮಾಡ್ಕೊಂಡು, ಕ್ಯಾರಿಯೋಟೈಪಿಂಗ್ ನಾರ್ಮಲ್ ಆಗಿತ್ತು ಅಂದ್ರೆ ಗರ್ಭಕೋಶ ತುಂಬಾ ಚಿಕ್ಕದಾಗಿತ್ತು, ಇಲ್ಲ ಬೆಳೆದಿಲ್ಲ ಸರಿಯಾಗಿ ಬ್ಯಾಂಡ್ ತರ ಇತ್ತು ಅಂದ್ರೆ ಅದನ್ನ ಮೇಯರ್ ರಾಕಿಟಾನ್ಸ್ಕಿ ಕುಸ್ಟರ್ ಹೌಸರ್ ಸಿಂಡ್ರೋಮ್ ಅಂತ ಹೇಳ್ತೀವಿ. ಸೊ ಇಂಥವರ ವಿಷಯದಲ್ಲಿ ಗರ್ಭಕೋಶದಲ್ಲಿ ಪ್ರೆಗ್ನೆನ್ಸಿ, ನಿಮ್ಮದೇ ಒಂದು ಗರ್ಭಕೋಶದಲ್ಲಿ ಪ್ರೆಗ್ನೆನ್ಸಿ ನಿಲ್ಲಕ್ ಸಾಧ್ಯ ಇಲ್ಲ. ಸೊ ನಿಮ್ಮ ಭ್ರೂಣಗಳನ್ನ ತೆಗೆದು ಲೈಕ್ ಮುಟ್ಟೆಗಳಿಂದ ಭ್ರೂಣಗಳು ಮಾಡಿ ಬೇಕಾದ್ರೆ ಬೇರೆಯವರ ಗರ್ಭಕೋಶನ ದತ್ತು ತಗೊಂಡು ಸರೋಗೇಟ್ ಅದ್ರ ಮೂಲಕ ಬೇಕಾದ್ರೆ ಗರ್ಭಧಾರಣೆ ಮಾಡಬಹುದು. ಇವಾಗ ಸದ್ಯಕ್ಕೆ ಅದು ವಿ ಆರ್ ಅಂಡರ್ ವೇಟಿಂಗ್ ಪೀರಿಯಡ್ ಅಲ್ಲಿ ಇದೆ, ಬಿಕಾಸ್ ದ ಬಿಲ್ ಹ್ಯಾಸ್ ಚೇಂಜ್ಡ್, ಗವರ್ನಮೆಂಟ್ ರೂಲ್ಸ್ ಚೇಂಜ್ ಮಾಡ್ತಾ ಇದೆ ಅದಕ್ಕೋಸ್ಕರ. ಸೊ ಗರ್ಭಕೋಶ ಚೆನ್ನಾಗಿದೆ ಬಟ್ ಚಿಕ್ಕದಾಗಿದೆ ಅಷ್ಟೇ, ಮಿಕ್ಕಿದ್ದೆಲ್ಲ ನಾರ್ಮಲ್ ಇದೆ, ವಂಶವಾಹಿನಿ ಟೆಸ್ಟ್ ಕ್ಯಾರಿಯೋಟೈಪಿಂಗು ನಾರ್ಮಲ್ ಇದೆ ಅಂದ್ರೆ ಅವಾಗ ಮಾತ್ರೆಗಳನ್ನ ಕೊಟ್ಟು ಬೆಳೆಸಿ 6 ತಿಂಗಳ ನಂತರ ನೋಡಿ ಗರ್ಭಕೋಶ ಚೂರು ಬೆಳೆದಿದೆ ಅಂದ್ರೆ ಅವಾಗ ನಿಮ್ದೇ ಓನ್ ಗರ್ಭಕೋಶಕ್ಕೆ ಭ್ರೂಣಗಳನ್ನ ಹಾಕಿ ಟ್ರೈ ಮಾಡಬಹುದು.
ಓಕೆ ಓಕೆ. ಸೊ ಶಾರ್ಟ್ ಆಗಿ ಹೇಳ್ಬೇಕು ಅಂದ್ರೆ ಒಂದ್ಸಲಿ ಡಾಕ್ಟರ್ ಹತ್ರ ಬನ್ನಿ, ಡಾಕ್ಟರ್
ಎವ್ಯಾಲ್ಯೂಯೇಷನ್ ಮಾಡ್ಕೊಳ್ಳಿ
ಮಾಡಿ ಆಮೇಲೆ ಡಾಕ್ಟರ್ ಏನ್ ಸಲಹೆ ಕೊಡ್ತಾರೋ ಅದ್ರ ಪ್ರಕಾರವಾಗಿ ಮುಂದಕ್ಕೆ ಹೋಗ್ಬೋದು. ನೋಡೋವರೆಗೂ ಸಲಹೆ ಕೊಡ್ಲಿಕ್ಕೆ ಕಷ್ಟ ಆಗತ್ತೆ ಅಂತ
ಎಲ್ಲ ಪಾಸಿಬಿಲಿಟೀಸ್ ಏನೇನ್ ಇರಬಹುದು ಅಂತ ನಾನು ಹೇಳಿದೀನಿ. ನಿಮ್ಗೆ ಯಾವ್ದು ವರ್ತಿಸುತ್ತೆ ಅಂತ ಗೊತ್ತಿಲ್ಲ, ಅದಕ್ಕೆ ನೀವು ಬರ್ಲೇಬೇಕು ಡಾಕ್ಟರ್ ಹತ್ರ.
ಓಕೆ ಓಕೆ ಓಕೆ. I think we're done with our time limit today. I'm already getting reminders from the organizers saying we've crossed our time. So let's wind up today's program. Very interesting topic that we took up today. So as a set of closing remarks, we can start with Dr. Anitha. Do you have any closing remarks to end the show today, Dr. Anitha?
Yes, sir. So as today's program, as we pull everything, mainly, as I said, there are 4 factors which are important. So today we are addressing about the ovulation. So if the other 3 factors like the tubal factors and uterine factors and the male factor, that is semen analysis, are normal, then if the ovulation is the only thing which we are finding it abnormal, then we can definitely go ahead with the ovulation induction with timed intercourse, provided there is that married life is less and age factor, that is both the couple's age is less than 35. Then we can definitely go ahead with the ovulation induction and timed intercourse. Depending upon their age, we can try multiple attempts or 2-3 cycles at least.
Okay, yeah, that's a good summary, Doctor. Thank you. Dr. Priyanka, over to you. Your closing remarks and take-home messages from your side.
So what I want the couples to understand is ovulation induction is a very safe method of treatment. It is effective, it is cost effective, it can give good results, but we need to give it in the right people at the right time. And it has to be done by the right people, so who are experienced in giving treatment and who are able to correctly monitor them and not pushing them into side effects like hyperstimulation or multiple pregnancies. So if it is done in the correct way, in the correct hands, it can give very good results. And but we must have practical expectations for that, where it will work out. As I was saying, there are many couples who come with the notion that doing IUI is something advanced which we are doing, but they must understand that if 4 to 5 cycles of ovulation induction with timed intercourse has failed, we have to look for other factors and go on to the next level of treatment. So it can be tried in a good set of people for a small amount of time. Again, reevaluate. If it works out, we can continue. If it doesn't work out, we have to go to other methods of treatment. So doing it in the correct way is very important. And that is what I want them to understand. In addition to the other measures which I was telling, there has to be efforts from the patient side as well.
Okay.
Then it works out best.
Okay. Thank you, dear doctors. It was wonderful talking to you both. Thanks for sharing your experience, expertise, and the knowledge. I'm sure the audience will benefit from what you told them today. Thank you, Dr. Priyanka. Thank you, Dr. Anitha.
Thank you.
So all our viewers, thank you for making time. All our 5 centers are in Bangalore. Doctors are available in the mornings and evenings. They are all fertility specialists. That means gynecologists who have done their super specialization in the treatment of infertility. We are known for our extraordinary success rates, ethical values, and humane touch. So do reach out to us for any treatment, advice, consultations, anything that you are planning. You can talk to us either by coming to our website and booking an appointment, or call us at 888 0000 909. Thank you so much. Have a fantastic weekend. Thank you.